Dr. Shannon Barris, who is an assistant professor of ophthalmology and neurology. She's an expert in both pediatric and adult neuro-ophthalmology, and she'll be discussing ophthalmic imaging and biomarkers of optic neuropathies in the pediatric population. Shannon?
Great, well, thank you, Diana. All right, well, good to be back. I have no disclosures. And today I'm going to talk about trying to let you guys know the differences between the feasibility in children versus adults, which Dr. Moss already alluded to, as well as recognizing the imaging opportunities that we have in children. So I'm going to start with a case. This is a patient of mine who had been followed by a prior provider for a few years. And when she went to that provider at the age of 9, she went there because she had severe headaches for 1 year. They found that she had severe optic nerve swelling. She had a full workup that included multiple lumbar punctures, MRIs, and they found that she had no vision loss and no visual field deficits during this time. So ultimately, she was given a diagnosis of optic drusen, in which I met her when she was 12 years old with the diagnosis of ODD. Her vision remained 20/20 in both eyes with no other abnormalities, including normal color vision. And her OCT, when I first met her at age 12, showed that her RNFL was 110 on the right and 121 on the left. And you can see that there was this drusenoid appearing nerve with no vessel obscuration and possibly some drusen poking out over here. Her visual field was normal. However, she comes back a year later with her for her routine visit. And at this point, now there's new obscuration of the vessels, which was unusual. For the last year, she'd been undergoing treatment for her headaches since they were severe, and she has now new visual field loss, which was quite interesting. And I was wondering, why is this going on? Is this the drusen? But why is her OCT showing an increase in the RNFL thickness in the right eye specifically? So before in which I wasn't worried, you wonder, now, should I be worried? As you look back at her prior OCTs that were taken at the institution prior to me, you can actually see that she had a similar bump in the retinal nerve fiber layer 3 years ago. So she went from 137 to 152, and then there was there was a resolution of that thickness. And then here we are in 2018 with another increase in her retinal nerve fiber layer and this new nasal defect that she has. So the question is, what is going on? So once again, at this point, I held for a little bit and looked at her again a couple weeks later, and that edema appeared to still be there. So we ended up getting another opening pressure. By this point, she has now had 5 lumbar punctures, 4 done prior to seeing me. And you can see her headache medication is quite a long laundry list of medications that haven't helped. So at this point, we wonder what is really going on, and could any of this workup have been avoided if we had a diagnosis of ODD and no other concern that there was something else driving this this edema. So the mother calls me with her second daughter in 2018, and she's frantic and says, I went to the optometrist and my other daughter now has a nerve that looks like it has drusen. At this point, I saw her, and her retinal nerve fiber layer was 260 on the right. And as I followed the sister too, I found that her visual field defects did accumulate, and she also had these fluctuations of her retinal nerve fiber layer thickness. So you question, what is going on? Is this mini NION in kids that are happening insidiously that we are missing? When I looked at the literature, there are some case reports. There's a 15-year-old that they gave a diagnosis of AION in the setting of optic drusen. There's another child in a retrospective study by Gia et al. Out of 11 kids that found significant edema that then had resolution. There's a 13-year-old also with the diagnosis of AION in the eye that has drusen in a unilateral case. And then there's also plenty of anecdotal tales from colleagues who have RNFL fluctuations seen in the pediatric population. And in these cases, they are not totally typical in that they don't have the acute vision loss that we see in our adult population with NION. They also do end up getting treated with Diamox many of the times, so that we have this sort of invariable change in medication that may or may not be causing any resolution of the edema by itself. So is this true that there could be many NIONs in these kids? Are these happening multiple times? I take back to you the timeline I showed before, in which we have these buried drusen around the ages of 4 to 6. Pseudopapilledema becomes a little bit more obvious between the ages of 8 and 12. Visible drusen pops out around age 12, and then they go on to have the superficial drusen with little change along with the buried drusen. But are these many fluctuations that we and my colleagues are seeing small NIONs? Is this the drusen moving forward? What could this possibly be? So looking at papilledema versus pseudopapilledema, and what do we have in order for us to follow these kids along their early first decade? And the imaging that we've had so far actually shows that we are not so good at it. There's a misdiagnosis in using just one modality in Dr. Pinellas and Dr. Chang's study in 2017. And then the Gia retrospective study by Gia et al. Also showed that you needed multiple imaging modalities for us to better identify these drusen. But in these cases when there's edema plus drusen, it seems as though the challenge is much greater. So what can we do and how can we image these kids? You've already heard from Dr. Liao and Dr. Moss about the modalities that are offered in the adult population, but I think it's really important to recognize, how are we going to do this in the children? So the gold standard recognized in 1999 was the B-scan ultrasound. And looking in just pediatric, everything here is pediatric cases. The Gia et al., which is a retrospective study, showed that 45% of cases were missed with a B-scan ultrasound, and they were missed because they were either deep or not calcified. In Petruskin's study of patients of familial drusen families, they followed kids starting from the age of 3 or 4 years old and found that actually the B-scan did not become positive until about 8 years old in some of their patients. So B-scan may not be helpful in this age group. Naomi found that the B-scan was better than autofluorescence, but still you missed 28% of the cases using just B-scan alone. And then there was a prospective study back in 1983 looking at 18 children that at least found that B-scans was helpful in the uncooperative patients. So I guess this is sort of a last resort, but at least something we have. And to the point that this is so easy in uncooperative kids, we're now seeing that ultrasound is being used in emergency rooms to help with pseudopapilledema versus papilledema. So the ability and the feasibility in the 3 to 8-year-old range, I'd say, is pretty feasible. We can hold a kid down and we can get a B-scan ultrasound of their eye. So moving on to fluorescein angiography, we found Dr. Chang and Dr. Pinellas down at UCLA found that there was a 97% accuracy rate of using fluorescein angiography in 19 kids of their study. They looked at 19 kids that had either papilledema or superficial or buried drusen, and they found that the fluorescein angiography was the most helpful. And then looking at the retrospective study by Gia, they show that actually combining both the spectral domain OCT and the FFA also showed a highest accuracy, but in this case, they only looked at the combination of both of them. But the fluorescein angiography is difficult. That would require an IV unless you're going to propose doing oral contrast. And we would have to have a nurse in our pediatric department, which we typically do not have. And it's just much more difficult for these kids to go through a fluorescein. So is that actually practical? Probably not. So looking at OCT, which we've already talked quite a bit about over the last hour, we know that these drusen can be uncalcified early on in these early age groups. So sometimes we can't actually identify the drusen very well. So is OCT really the best? Looking at OCT EDI, looking a little deeper into the tissue, we do have 2 studies so far that have used this in children. And the Copenhagen study by Dr. Hammond's group, as well as the UCLA study I already talked about, which were both prospective studies, did show that they were able to use an OCT EDI in at least 11-year-olds in Copenhagen study, and in at least there was 1 5-year-old or a 6-year-old, based on the age ranges that I saw from the study, that show that the UCLA study was able to get an EDI, an OCT EDI on that young of a patient. But now, as of 2018, the EDI is considered gold standard, but are we really able to do this in children? Doing an OCT EDI actually takes quite a bit of time. The kid has to sit as still as a statue for about a minute to 2 minutes, and then if they move, we have to redo it. There is algorithms for us to kind of move and then come back to where that was scanning and to take up from where it left off, but this is quite difficult. Then looking at OCTA, there really are no studies of the young kids using OCTA, primarily because it takes so long to actually acquire one of these images. So I'd say the feasibility of both the OCTA and EDI in this very young population is quite difficult and will be a challenge for us. And there are no studies using VEP in the optic drusen group of children. However, it is very well understood in this age group, even down to infants. So it is feasible, but are we really going to continue to use that and add it to the modalities that we use? So here's the adult OCT protocol that was recommended in the Journal of Neuro-Ophthalmology by the Copenhagen group. And this, if you look at all these scans, there's no way you're going to get a 5-year-old through these scans. Maybe some of them, maybe half of them, but a really good 6-year-old possibly. So we just need to rethink, how are we going to compare oranges to apples? If we really want to look at this as a longitudinal study of children through adulthood, we're going to start with different imaging modalities as a child and then have to transition as we get older. So are we really moving oranges to apples, and how do we then resolve that issue? So if we think of actually looking at apples to apples, there are handheld OCTs in the population that we can use for children, or in the children population. We can use it with infants, but there is no automatic segmentation. It is years behind the technology for the OCT EDI. And there's also a very steep learning curve for physicians to be able to use this, or technicians to be able to use this. And lastly, some of these kids, sedation is needed in order for us to get good enough scans and to scan long enough through the optic nerve head. So I'm not sure if we're really going to be able to do apples to apples, but I think technology does need to catch up in the pediatric world for this to happen. So back to our 14-year-old case of our girl who had headaches and then had this fluctuation of her retinal nerve fiber layer. She's already gone through the B scan, the OCT, the autofluorescence, the visual fields. And as we move on to this Tour de France, can we stop? What is it that we can see on imaging that would help us prevent us from moving on to getting an MRI with sedation and lumbar punctures and labs in our kids, because we just can't tell the family this is or is not a brain tumor. So in summary, I wanted to make sure you guys understood that the OCT EDI is now the new gold standard in adults, but the summation of multiple modalities are still needed in the children, because we may not be able to actually do an OCT EDI or an OCTA, or these fancy things that we're moving forward with in the adult population. And that innovation is needed for these children, for us to be able to compare apples to apples as we move forward with longitudinal studies. Thank you.
Thank you very much, Shannon. That was terrific. This is open to any questions from our participants. Shannon, I want to start off with a question. How often do you have to place patients under anesthesia to really do the complete examination that you want to do for your pediatric?
For the kids, so we often lump it together. So a kid comes in with a swollen nerve and say they're 6 years old. We will often lump it together with an MRI and lumbar puncture, because we don't want to go through. If we see nothing on the MRI, then the next option would be the lumbar puncture. And we don't actually want to put them through multiple anesthesia events. So sometimes it's an all or none workup where we just go through with everything. I'll do the eye imaging, we'll do the lumbar puncture and the MRI. The other thing is, if we're going to put them down anyways in order to get imaging of the eyes, then should we just also get the MRI because we're already going to be under anesthesia? So these are the questions that we have to deal with in pediatrics, but don't actually have great evidence to support one or the other. I would say I do it quite infrequently. I would follow kids more often, but if they have symptoms such as headache and vomiting, obviously we move much more rapidly to sedation, to imaging modalities with sedation. So I know we're running out of time, so I do want to move on. I want to introduce Diana Doe, who's going to be speaking to us on, well, I got to switch over to my sheet here. He's been working on us on ophthalmic imaging and choroidal neovascularizations in optic drusen implications for vision loss. So thank you, Diana.